Good evening, everybody. Hi, my name is Claire Hedgespeth, and I am the co-president of the UVA Alumni Club of Prince William County. I am a legacy who graduated from college in 2007 with a BA in music and in 2019 with a certificate in public relations. And first off, I just want to say thank you so much for joining us this evening. I'm happy to see so many people interested in this panel today. The UVA Alumni Club of Prince William County encompasses nearly 350 square miles from Woodbridge and Dumfries all the way to Marshall. It includes Manassas, Warrenton, Haymarket, and Gainesville. As a club, we are dedicated to serving our 11,000 members with student celebrations every spring, summer kickoff parties, and game watches all throughout the school summer kickoff parties and game watches all throughout the school year. We have opportunities to meet other Who's in the area and future Who's, eat at various local spots, and volunteer in the community. So we hope you'll look out for those event invites. We are excited that UVA Community Health is looking to expand its presence in our area. And with 50% of our members being over the age of 40, we look forward to hearing what new things are happening in cancer research and treatments. So now I'm honored to introduce Eric Shannon. Eric serves as Chief Executive Officer of UVA Community Health. UVA Community Health includes an integrated network of outpatient services across Culpeper and Northern Virginia, together with UVA Culpeper Medical Center, UVA Haymarket Medical Center, and UVA Prince William Medical Center. Eric came to UVA Community Health from his role as partner at Grant Thornton, a global consulting and advisory services firm, where he helped lead the transition to work to integrate UVA Community Health into UVA Health after UVA Health became the full owner of the regional health system in July 2021. Eric has more than 30 years of healthcare experience leading organizational and operational strategy, including strategic planning, operational improvement, restructuring and reorganization, financial planning, and physician practice management. Along with overseeing day-to-day patient care operations, Eric is partnering with UVA Community Health senior leadership and several internal teams to continue the work to integrate UVA Community Health into UVA Health. Eric, thank you so much for being here.
Claire, thank you very much. And we are thrilled to be able to host this really dialogue with our alumni. And we just love the chance to be able to connect in this way and talk about such an important topic such as cancer and really be able to answer key questions that you have. And we always love doing that. But with our UVA alumni, it's really special. The American Cancer Society, according to them, there is a risk of developing cancer in your lifetime for men, 1 in 2, and for women, it's 1 in 3. And incidents are rising for younger adults as well. So there's probably no time like the present to really have important conversations about cancer because in some shape or form, it has either touched you or probably someone you know or someone you love. With that, we prepared a great panel of physicians who know all of about cancer and caring for patients in Northern Virginia. And I would like to introduce you to the first one who's going to host our panel, and that is Dr. Zan Zaidi. He is the Chief Medical Officer of UVA Community Health, which are our facilities in Northern Virginia. Zan?
Thank you, Eric, and good evening, everyone. I'm Dr. Zan Zaidi, Chief Medical Officer of UVA Health in Culpeper and Northern Virginia. Tonight, it's my great pleasure to introduce you to just a few of the members of our extraordinary team from UVA Health Cancer Care Gainesville. You'll hear presentations tonight from Drs. Pranav Patel, Ali Majoub, Ian Greenwald, and Maura Sutton. You'll also get a chance to meet Dr. Felicia Blow, the Executive Director of our foundation. Each of our physicians is a board-certified specialist, meaning they have advanced training verified skills, and a lasting commitment to the latest in cancer treatments and research. Our physicians lead multidisciplinary teams that partner with patients and their families throughout their entire journey. They are deeply committed to offering high quality, individualized cancer care right here in our community. As Eric mentioned, this is an especially exciting time for us because of UVA Health's expansion of services in Northern Virginia. In order to meet the needs of our community, we have enhanced our program to now include multiple specialists all under one roof in Gainesville. So this includes medical oncology, radiation oncology, surgical oncology, cancer navigators, access to clinical trials, and so much more. So our hope is that our program tonight gives you just a glimpse of the world-class services that are right here in our backyard. But before we begin, I would like to cover just a few housekeeping topics. Our webinar tonight is being recorded. And so if you can think of a question for our experts, we invite you to please use the Q&A box on your screen. We have saved time after the presentations at the very end of tonight's program, and we will attempt to answer as many of them as possible. We'll be sharing a link to the content with our registrants afterwards so that you can revisit the content, and we encourage you to share it with others as well. Our first panelist tonight is Dr. Pranav Patel. Dr. Patel is a medical oncologist and hematologist who did his residency training at Walter Reed Army Medical Center. Dr. Patel treats a broad range of patients, and he has a specialty interest in lung cancer. Dr. Patel, the floor is yours.
Yeah, thanks for having me. And I appreciate this opportunity to share some information about what we as medical oncologists and hematologists do. I know through a patient's cancer journey, they're seeing multiple different providers, navigators, nurses, genetics counselors, nutritionists, dietitians, social workers. And I would like to say that as the medical oncologist, the hematologist, we are the core a part of a patient's journey through the system. And so I want to take a few minutes to kind of explain what a medical oncologist, what a hematologist is, and then also kind of go over the philosophy we use to help care for our complex patients. If you can go to the next slide. So medical oncology encompasses treatment of cancer of really any part of the body. If you look at this slide and graphic, if you think about cancer can occur from really head to toe of any body part, body organ, body surface. And we help navigate and treat throughout the spectrum of disease. Now, my specialty interest is in lung cancer, but I do treat all kinds of cancer to include breast cancer. Some of my patients who are fortunate enough to get the transfer the care to our wonderful breast surgery team that you'll meet today. So in the context of this slide, I just want to just highlight, just as Eric Shannon mentioned, that cancer is very prevalent in our society, in our community. And if you go on a plane, a train, or a bus, you'll probably sit next to somebody who is a cancer survivor. So that's a really sobering thought in my mind. You don't realize what people go through in their lives. And a lot of patients you'll see are living a normal life, not knowing that they had gone through a journey of cancer. Next slide. To piggyback on the medical oncologist, sometimes when patients come to our office, they're referred for hematology concerns, which sometimes frightens patients when they come into a center that says hematology and oncology. Oftentimes when patients are presenting with benign disorders like anemia or blood clotting disorders, which are not technically cancerous processes, we help navigate through the benign and the malignant hematologic disorders, which do share an overlap with medical oncology, such as acute leukemia, lymphoma, and bone marrow failure disorders. Next slide. So I know my colleagues are going to go over certain concepts of cancer staging, and I don't want to take too much time going over that, but really cancer is staged in multiple ways. As a layperson, oftentimes there is confusion about how doctors present patients with their staging, But really, each cancer has a different stage. Some cancers are stage 0, where they're in the precancerous stage, where treated either with surgery alone or with surgery with a combination of therapies like radiation, or in breast cancer, hormone blocking therapies if cancers are estrogen sensitive. Those cancers can be really well treated in an early stage. Some cancers have stages of 1, 2, or 3, depending on the size of the tumor, whether lymph nodes are involved, and invasion of local areas. And then some cancers, like head and neck cancer or lymphoma, may have a stage 4 designation, which in a layperson, sometimes when you hear stage 4, you think, oh my gosh, I'm going to pass from this disease and it's not, all hope is lost. And that's not necessarily the case. So we do have many patients who have curable stage 4 disease. And it's really important to talk to your treatment team about what these staging designations really mean to you. We also have patients who advance disease, where it's cancer has spread or metastasized to different places, different organs, which our goals become slightly different in management, where we go from a curative intent to really treating the cancer as a chronic disease. Oftentimes, when we think about chronic diseases, we don't think about cancer as a chronic disease, but cancer is and can be treated effectively as a chronic disease, sometimes in some cancer settings in decades long treatment courses. And so really, I look at advanced stage and metastatic disease as a chronic disease, much akin to patients who have heart disease or lung disease or dialysis or other autoimmune disorders. Cancer can be treated as a chronic disease. And then, unfortunately, sometimes we do oftentimes get patients who have terminal disease, where no matter what we do or try, we may not be able to extend their life or help them through their cancer journey with a survival benefit. And so we also are really well trained to help treat patients who are in advanced stages of disease, where our goals really are really to make them feel better, improve their time that they have till they can spend with their family and loved ones. Next slide. So really, when a patient comes to me, I try to personalize their care, factoring in their own features of their diagnosis, their cancer, their stage, their tumor specific findings. We also individualize our patients' cancer care based on their own values. Everybody's different. Everybody comes to this journey with a different perspective, from the 20-year-old mom of 3 through the 90-year-old great grandfather. They all come to this perspective with different set of values, belief systems, and goals, and we try to respect those wishes of what their goals are. The benefit of being a part of a large institution like UVA is that we have access to multidisciplinary approaches through our partnership with our main campus, which is a NCI, National Comprehensive Cancer Institute, designated care of excellence facility. And so we have really well integrated resources with our subspecialty experts, doctors who see just specific types of cancers, who are able to provide a support network for us in the event that things are needed for specialty care. One of my main focuses as a physician, one of the reasons I chose cancer medicine, is I felt that cancer medicine provided the opportunity for myself to really be a part of a patient's journey. I think of it as kind of a full spectrum. Nowhere else in medicine will you be able to see a patient's ups, downs, strengths, weaknesses, learn about their character, their family, their ideals, their wishes, than I think in oncology. And so part of my responsibility in patient care is to ensure that the patient is informed, they're well educated about their disease, they know what treatments they're receiving, why they're receiving them, the side effects that they're expected to have. We try to provide strong emotional and mental health support when needed. We have a robust system where we have social workers, navigators, nutritionists, providing a full spectrum of care for patients. And really, my goal as a medical oncologist is to advocate for you. My goal is to make sure that we leave no stone unturned. We try everything that's available to our resources, and even if they're not available to our resources, finding places for you to get the care you need and you deserve. We also have this great survivorship program where when patients are finished with their cancer treatments and in the post-treatment recovery phase, we provide the follow-up care, the survivorship care that is really nuanced to medical oncology, hematology, radiation oncology, and surgical oncology, where we follow the patient from day 1 to day 5 or beyond, wherever their journey takes them until the survivorship phase ends. And oftentimes patients still come back to us 10 years on wanting to still see us at least for an annual check-in. So we provide that support, we provide the reassurance, we provide the backup to the primary care teams who really appreciate our input on long-term survivorship care. Next slide. So this is a brief slide of our hub and spoke model. We have 3 excellent medical centers, Culpeper, Gainesville, and of course our main campus, Emily Currick, that we share patients back and forth. So you may be referred from one place to another, but all systems are go within our organization. Next slide. So again, our goals, or my goals for patients in our journey, is to maximize their survival, minimize the side effect burden of treatment, at the same time maintaining their quality of life and controlling any symptoms they have of their disease. And during this journey, we utilize our expert resources, our subspecialty care with our surgical oncology team, radiation oncology team, and the vast network of support systems we have. Thank you, Zan.
Thank you, Dr. Patel. That was a wonderful overview of a very broad topic. Our next panelist is Dr. Ali Majoub. Dr. Majoub, I invite you to turn your camera on. Dr. Majoub is a medical oncologist and hematologist who trained at the New York Presbyterian Methodist Hospital, which is part of Weill Cornell Medicine in Brooklyn, New York. He treats a broad range of patients and has a special focus on breast cancer. Dr. Majoub, ready for your presentation.
Thank you, Dr. Zaidi. My pleasure to be here. As Dr. Zaidi said, and Dr. Patel, I'm a medical oncologist, and we'll talk a little bit specifically about breast cancer. So basically, medical oncologist, again, where are the medication treatment part for the cancer management? We decide the treatment plan and to what to give and how to manage breast cancer with our colleagues from the surgical oncology and the radiation oncology side. So this slide just showing breast cancer stages and how it starts from the far left, where we see the pre-malignant cases, what we call either atypical hyperplasia, and those can form into the ducts of the breast or the lobules that you can see in the diagram in the center of the slide. To the right, we see the ducts, how it looks normal with 2 rows of cells, and then slowly progress to the precancerous stage. And all of that is still pre-malignant, still requires surgical intervention. Once we cross that dotted line, the cancer cells can develop, and that happens usually after a mutation. So the first stage, as Dr. Patel mentioned, the stages of cancer in general, this is specific for breast cancer. Stage 0, what we call it in situ, and where it happens inside the ducts, but did not breach the wall. And then if it progresses without treatment, it can breaches the wall, and that what we call invasive, and that can be a stage 1 or 2, especially if that cancer cells can reach the lymph nodes locally, or eventually it may reach the bloodstream and spread throughout the body, and that's what we call metastatic disease or stage 4 disease. Next. So a lot of questions we get when we see patients and talk about breast cancer, they ask, what type do I have? And what does that mean and why it's important? So breast cancer is not all the same. There are different types depending on what we call the receptor status. But in a simple way, there are three markers on the cancer cells. And one of them, we call it estrogen positive. And that basically means those cancer cells get stimulated by the estrogen itself, the hormone that we all have, women and men, they have estrogen levels. The second marker or receptor is progesterone. Same idea. Progesterone can contribute to the growth of those cancer cells. And another marker we have is what we call HER2 as a short. And this is a receptor on the cancer cells kind of signal the cancer cell to grow and divide rapidly. Next. Next slide, please. So breast cancer can be a combination of any of those receptors. And you can have, the patient can have an estrogen positive or estrogen negative in combination with HER2 positive or negative, but also can have none of those receptors. And that's what we call triple negative breast cancer. Next slide. This is just a diagram to show the combination. It's basically a repeat of what we just mentioned, a combination between hormone positive, which is the estrogen positive, or HER2 negative, or positive, and eventually maybe even triple negative. Next slide. So the reason I mentioned those types, and I mentioned that to patients, because having those receptors or types of breast cancer decides what treatment the patient can get. Not every patient with breast cancer will get the same treatment. And again, we hear that a lot from our patients, having a relative or a friend or a colleague that had this type of treatment, like a pill, while this one getting an intravenous infusion and the other one getting chemotherapy. So how do we decide which one get what? Of course, stage matters on what we give, but also that type of breast cancer. So chemotherapy, the old-fashioned chemotherapy, basically, given most types of cancer, basically can be given intravenous or oral, and it just stops or slows cancer growth, but also may cause some harm to the healthy cells, and that's what the side effects come from with chemotherapy. While if we go to the second type, what we call endocrine therapy or hormone blockers. So those are specific to breast cancers who have estrogen positive, because those cancers treatments are specific to the estrogen receptor. And the way it works, it basically works on stopping the hormones from fueling the breast cancer growth. So that's a type that not every cancer patients will be receiving unless they have that receptor. The other type, the third type, is biologic or targeted therapy. Those are not chemotherapy, but also mostly given intravenous. There are some targeted therapy now in a pill form. Those are usually targeted into a specific mutation or a specific target. So the HER2 we mentioned earlier has a specific medication that targets this HER2 signal, and it would be appropriate for patients with a breast cancer with HER2 positive. We have also other medications that target specific mutations that we now can test in a advanced blood test or on the tissue biopsy. And lastly is immunotherapy, which is been there around for 10 years or so, but recently got introduced into the breast cancer treatment. And it actually works in a way that works with the patient immune system to reprogram it to fight the cancer. Cancer cells can escape our immune system. That's how we generally develop cancer. And these medications reprogram it to re-recognize those cancer cells as bad cells or foreign bodies, and it try to get rid of it. Those usually are intravenous infusions, and mainly for now are approved for the triple negative breast cancer. So those when we don't have a target therapy or hormone blockers for them, immunotherapy is introduced in a stage 4 or early stage triple negative breast cancer. Next slide. So this is just part of the breast cancer treatment. This is only the medical part. We work with our partners from the surgical oncology and radiation oncology. A combination of all of that will be or might be needed. Patients, again, can ask, this one had radiation, the other one did not, or I had immunotherapy, the other patient had hormone blockers. A combination of any of those will be tailored specific to this patient based on their characteristics and the tumor characteristic and stage and receptor status. Next slide. So lastly, we get a lot of concerns from patients when we talk about chemotherapy or medical treatment, and that sometimes comes from their family member experience or a friend experience where they immediately think, I'm not strong enough to be handling this chemotherapy or this drug, and I don't want to try it. But we always get surprised on how strong our body is, and we always tailor even the medication or the dosage or the frequency and how we give it based on the patient health status, age, and comorbidities. And thank you so much. I'm happy to receive any questions at the end. Zan.
Thank you, Dr. Mahjoub. That's such a complicated topic to cover in eight or 10 minutes. You did a wonderful job. Before I introduce our next panelist, I wanted to just a quick reminder to encourage our registrants to use the QA function if you have any questions you'd like for us to get to at the end of the presentation. Our next panelist is Dr. Ian Greenwalt. Dr. Greenwalt is a breast surgeon who did his residency at Case Western Reserve University, followed by a breast surgical oncology fellowship at Georgetown University. He is the medical director for breast surgical oncology for UVA Health in Northern Virginia. Dr. Greenwalt, your turn.
Thanks, Dr. Zaidi, and thanks everyone for attending tonight. So I'm going to be chatting about the role of breast surgical oncology, but then also I'd be remiss being Breast Cancer Awareness Month if I didn't give a little plug for breast cancer screening and just kind of the reason why that's important. So I will kind of piggyback on what some of my great colleagues here have already kind of laid out, and then we'll go from there. Next slide, please. I have nothing to disclose, no financial relevance to this topic or any conflicts of interest here. So next slide, please. So pretty busy slide, but I'll try and break this down a little bit. And the purpose here, as the title suggests, is to give a sense of what does modern breast cancer care look like. And Dr. Patel and Dr. Mahjoub have done a nice job of kind of laying some of this out. But as you can see in the left-hand column, it's really based upon multidisciplinary coordinated care. And so there's a lot of different subspecialty and specialists involved here, because breast cancer care gets pretty complicated. And it's everything from the diagnosis and with our breast radiologists to resection and removal of cancer with breast surgical oncologists like myself, to systemic treatment with Dr. Mahjoub and the medical oncologist, and Dr. Moore Sutton, who's our excellent radiation oncologist. We'll chat about the role for radiation oncology. We also work very closely with reconstructive surgeons, which is a fantastic offering that we have through all of our UVA sites, and all of this multidisciplinary care, whether we're talking down in Charlottesville or Culpeper or in Gainesville is available. And then also things like genetic testing, what we call tumor genomics, or knowing about the specific genes and biology of a given cancer, physical medicine and rehab services for our younger patients, fertility preservation, and then psychosocial support. So lots of different things that go into kind of modern multidisciplinary care. The way to think about this more globally, though, is these two other columns in the middle and on the far right of the screen. So local therapy is what encapsulates breast surgery and radiation oncology. So this is really about removal of gross disease and control and reduction of local recurrence, versus systemic therapy on the far right, which is what Dr. Mahjoub had a chance to discuss very well before, which treats the entire body. And the idea here is that it reduces both the risk of local recurrence, but also systemic disease, any cancer that is already present or looking to cause disease at distant sites in the body can be addressed with systemic disease. And so going back to the middle column, there's breast surgery, which is my area of expertise, and roughly boils down to what we call lumpectomy or partial mastectomy versus patients who need a full mastectomy or removal of the entire breast. Oftentimes with certain types of invasive disease that has a possibility of going to other parts of the body, we'll also sample some of the related lymph nodes that are present underneath the arm, or what's technically called the axillary area. And then lastly there, radiation, which typically happens after surgery or sometimes after surgery and systemic therapy, which is very effective at destroying any dormant or microscopically present cancer cells and really reducing the risk of disease recurrence. Next slide, please. So this is a cartoon schematic to demonstrate the most common operation that we do. And so this is a lumpectomy surgery, also called partial mastectomy. And in some situations, this is paired with what's called a sentinel lymph node excision. So what this all means is, so lumpectomy is kind of what it sounds like. It's removal of the area of disease, but preservation of the rest of the healthy breast. And sentinel lymph node excision refers to the sentinel or the draining lymph nodes related to the breast, which are present underneath the arm. The vast majority of these lymph nodes are not a part of the breast cancer process. And so this is a selective way of choosing the lymph nodes which are most likely to be affected by disease in the breast, and then leaving other lymph nodes alone. And so what the diagram is, or the cartoon schematic down here is showing is a patient with a breast cancer and the anatomy of the breast cancer relative to the lymph nodes in that region. And there's different ways to do this, but the most common way of doing it is injecting a dye and potentially some nuclear particles into the breast that then travel to the lymph nodes. It can be detected there and selected, choosing lymph nodes that are most likely affected and sparing those that are not. And then the one thing that has changed here is we're much more selective about the patients that we do this in versus those that we don't. And a great offering that that we have in our program too is a non-nuclear base for this, or using something that is based with these dyes and different types of liquid iron that can be injected, as opposed to the need for injecting nuclear particles. So this is just the overview of lumpectomy and sentinel lymph node excision. And on the next page, we'll talk about the other common operation that we do, which is mastectomy. And so in the middle of the slide here, myself or other surgical oncologists will perform in certain patients based upon their diagnosis, the volume of disease, and patient's wishes, removal of the entire breast or mastectomy. And these different arrows are pointing to the different options that we have afterwards in terms of how do we want to address the appearance of the breast after the surgery has been performed. And so there are a fair number of patients that choose the option on the left-hand side of the screen, which is what's called a simple mastectomy or flat aesthetic closure. This is for patients who do not wish to have reconstruction, and oftentimes will choose to wear prosthesis in their clothes, or otherwise just go without any form of reconstruction. On the lower part of the screen, this is something called autologous reconstruction, which basically means using someone's own tissue to recreate the shape and appearance of a breast. And this can be done in lots of different ways. The example that's given down here is what's called a deep flap, which is tissue that's taken from the abdomen and moved into the chest to recreate the mound of the breast. This can also be done by taking tissue from the side or from the back. This is something that is done primarily with the deep flaps in our larger centers in Charlottesville, but can also be done in the community health setting too, particularly when we're talking about the far right example with implant-based reconstruction, or certain types of local flaps or rotational flaps that are taken from the side of the body and moved in. And as I mentioned before, on the right-hand side of the screen here, the most common type of reconstruction that's usually done is an implant-based type of reconstruction, where the breast tissue is removed, and then at the same operation, a reconstructive or plastic surgeon is able to place either a temporary implant or a permanent implant, which recreates the shape and contour of the breast. Next slide, please. So the first portion of this discussion was talking about the role of breast surgical oncology, but the larger theme for this month, and then also for the topic of breast cancer, is kind of the epidemiology or the statistics behind it and why it's so important. So breast cancer is the most common female cancer in the United States. The incidence of breast cancer is unfortunately relatively common. About 1 in 8 women, or 12% of women who do not have underlying genetic mutation or predisposition to breast cancer, can be affected by breast cancer. This translates to about 360,000 new breast cancer cases diagnosed annually, and about 84% of these women are over the age of 50. Breast cancer is also the second most common cause of female cancer death in North America, only second to lung cancer. This translates to roughly about 56,000 deaths annually. That's a big number and can be sometimes a scary number, but we've made a lot of progress when we compare this to decades prior. Unfortunately, there are groups of women that we know are at higher risk, and so non-Hispanic Black women oftentimes have the highest mortality rate when compared to other ethnicities in the United States. But on a positive note, since the late 80s, early 90s, breast cancer mortality rates have decreased dramatically by about 44%. This means there's been about 517 or 518,000 fewer breast cancer deaths from 1989 to roughly 2022. We are starting to see, while there's improvements in mortality rates, higher incidence and diagnosis of breast cancer amongst younger patients. So patients younger than 50, we do see an increase in incidence, or the number of diagnoses, in white women and Asian American women. And lastly, at the time of diagnosis, there are about 10% of patients who can palpate a breast mass. So that means there's about 90% or so who do not, and we often pick up on this on screening. And unfortunately, there are about 5% of new diagnoses that are present as advanced stage or metastatic. Next slide, please. So why is breast cancer screening important? So there is a lot of data over the last few decades that shows that breast cancer screening saves lives. And the main purpose of that is because the vast majority of breast cancers can be diagnosed before they're palpable, when they're at an early stage, and early stage oftentimes translates, in the vast majority of times, translates to more options in therapy and better long-term outcomes. And as noted here, early stage allows for a wider range of more effective therapies, such that with most early stage breast cancer, stage 0, 1, and some stage 2 cancers, the 5-year survival rate approaches about 99%, which is outstanding. And then at 10 years for these cancers, there's about a 95% survival rate. And a lot of this is due to improved screening technologies, which is a credit to our breast radiology colleagues. A lot of this is due to patient and primary care awareness, major advances in breast cancer research, improvements in the types of therapies that Dr. Majub, Dr. Patel mentioned, but then also some of the local therapies that Dr. Sutton is going to discuss as well. And that has translated to these major improvements in mortality. Next slide, please. So this is a very nice slide that summarizes what patients should be doing when it comes to breast cancer screening, because there's a lot of information out there, variable information depending upon what sources you go to. But the American College of Radiology, the Society of Breast Imagers, and most of us who subspecialize in breast cancer care, these are the general guidelines that we follow. So women at the age of 30 should be meeting with their primary care doctors, whether it's their internist, their nurse practitioner, their gynecologist, and undergoing a risk assessment, which is basically a clinical exam and a history to figure out if they are at higher risk. If they're at average risk, then at 40, they should be undergoing annual screening mammograms. And the gold standard there is what's called a 3D or tomosynthetic digital mammogram, which is offered all throughout the UVA system. There's no cutoff for when mammogram should stop. If someone is 75 or older, there should be a discussion about their life expectancy and the pros and cons of going forward with mammography. But with the general life expectancy to 85 for most American women, it still is reasonable to continue with screening mammograms until 75 or older. Next slide, please. And so what should people know? And this is the end of my presentation, where I tried to hammer home about not just screening, but being proactive. And so things that you should be aware of is, so again, 85% of breast cancers are asymptomatic, and they're going to be detected on mammogram and at early stage. So that's good news, but it also emphasizes the importance of screening. But things that should come to your attention that a provider should be aware of, whether it's your primary care physician or a breast cancer specialist, has to do with things like a new mass in the breast that's firm or fixed to the skin or to the chest wall, skin changes, meaning if this breast is looking very red and there's pitting or what we call peau d'orange of the skin, any unexplained spontaneous clear bloody nipple discharge, if the nipple is retracted into the breast and not coming back out, or if there's any swelling or masses underneath the arm in that axillary or armpit area. These are all things that for the vast majority of patients, we can give them peace of mind that it's okay, but there are those situations that should be evaluated by a professional just to make sure everything's okay. Next slide, please. And lastly here, this is really the proactivity slide. So how can we empower our patients to reduce their risk and be proactive about their breast health? So we know that there is excellent data out there to say that patients who live a less sedentary life, who are exercising and active, overall their health is better, but their breast cancer rates are lower too. So the goal of about 30 minutes a day, 5 days a week, can translate to about 20 to 30% risk reduction in breast cancer. It's not that you have to be doing grueling exercise for 30 minutes every day, but just being up and moving around and walking, that checks that box off. Also maintaining a healthy weight, because we know that if we hold on to extra fat cells, some of those fat cells can produce some of these precursors and active agents that lead to stimulation of hormones like estrogen that can lead to breast cancer growth. Breastfeeding is a good thing. So we encourage our patients who are considering having children or have children to breastfeed, because whether it's 12 months consecutively or with multiple pregnancies, we do see a risk reduction associated with breastfeeding. And alcohol intake. While there aren't any strong national recommendations for abstaining from alcohol, there is a safe amount that most patients should be consuming. And this is true for their overall health, but definitely relevant for breast health too. So limiting alcohol intake to about 3 to 5 drinks per week stays within a relatively safe range there. And I believe that takes me to the end of my presentation. So thank you for your attention, and thank you all for having me this evening, and I'll pass things back to Dr. Zaidi.
Thank you, Dr. Greenwald. That was fantastic. When I see what you do for your day job, I marvel that you're able to make it on time to these events. Our next panelist is Dr. Maura Sutton. Dr. Sutton is a radiation oncologist who trained at Columbia University. She has a special interest in breast cancer, and Dr. Sutton serves as the co-medical director for radiation oncology services in Northern Virginia. Dr. Sutton.
Thank you, Zan. I'm happy to be here and talk to you all about radiation. So next slide. So you already heard a bit about this tonight, but the pillars of oncology treatment are radiation, medicine, which includes chemotherapy, and surgery. And we do take a multidisciplinary approach here at the Cancer Center at Gainesville. One of the really important components of this are our tumor board meetings. We have 2 tumor boards a month, which are dedicated just to breast cancer patients. At these tumor boards, we have the representatives from the multidisciplinary team present, and we review and discuss new patients. This allows us to coordinate the care and ensure that patients are receiving the best possible treatment. So I'll just briefly go through this because we went through this earlier, but the treatment team is radiation, the medical oncologist, surgical oncologist, plastic surgeons. They're all present at these tumor boards. And we also have the diagnostic team, which are the pathologists, the radiologists, and the medical geneticists. So just go on to the next slide. So the goals of radiation treatment, we want to provide excellent local control and improve survival. We want an excellent cosmetic outcome, and we want to minimize long-term toxicity. Next. So radiation works, it damages the genetic material in the cancer cells so that they can't reproduce. Normal cells can repair themselves after radiation, but cancer cells cannot. Here at the Cancer Center at Gainesville, we have state-of-the-art technology. We have 2 TrueBeam linear accelerators that are equipped with Align RT, and we have a 4D CT scanner for planning. This photo shows our newest machine that we got about a year ago. Next. So our new machine has what's called Align RT. And what this is it uses these 3D stereo cameras, which are tracking the patient's movement before and during radiation. So it allows for a faster setup and ensures an accurate delivery, even to millimeters. So when the patient is correctly lined up, the therapists who treat them, they're watching this monitor that you can see on the left, and it's showing that the breast, in this case, the left breast, is set up correctly as it is green. Next. We offer some advanced radiation techniques for our breast cancer patients. These include prone breast radiation, deep inspiration breath hold, and partial breast radiation. So the traditional positioning for breast treatment is on the back in the first picture, the supine treatment. Prone breast radiation has the patient lying on her stomach. So what that does, it allows the breast to fall away from the chest wall and away from the lung and the heart. So you can see on the left side, this shows a patient on her back, and the radiation beam is treating the right breast. But you can see it's also going behind the chest wall, and there's some radiation to the ribs and to the lung behind there. And if this were on the left side, there would also be some heart. On the right side, you see the prone setup. You can see the breast has moved away from the chest wall. So now we are able to put the back of our field in front of the chest wall, in front of the ribs, and there's no radiation to the heart or the lung. Next. So the benefits of this technique, it reduces skin toxicity, it minimizes the heart and lung dose, and it decreases the risk of a second malignancy. I want to say that I'll go back, sorry. We were the first center in Virginia to offer prone breast radiation, and we're still one of the few in the state that is doing prone breast setup. Sometimes it is necessary to treat patients in the supine position on their back. If this is the case, then we use a technique called deep inspiration breath hold to avoid treating the heart. So what this involves is the patient takes a slow, deep breath in and holds it for about 20 seconds. When you do that, it moves the heart away from the chest wall. So you can see what this looks like in treatment. On the left, you're seeing the breath hold technique, and you can see the heart is now away from our radiation field. On the right is free breathing. So if the patient does not do that, the heart will be right up against the breast, and a portion of the heart will be in our field. Next. So this shows just the breathing trace of a patient. So as the patient takes a deep breath in, once they reach the window in which the heart is away from the chest wall, the beam goes on. And when they exhale and they move out of that window, the beam goes off. So this way we ensure that the beam is only on when the heart is away from the breast and the chest wall. We also offer partial breast radiation. So sometimes we don't need to treat the entire breast, and we can treat just the tumor bed area that was removed at the time of surgery. This treatment uses our most targeted technique, which is called intensity modulated radiation, and it's delivered in only 5 treatments. So the future for radiation, technical advances continue to reduce the acute and late radiation toxicities. Radiation courses continue to get shorter. The standard of care used to be 6 to 7 weeks of radiation. The vast majority of patients will now receive only 3 to 4 weeks of radiation, and many patients are candidates for our 5-day regimens. Radiation continues to play a vital role in the treatment of breast cancer. It improves local control and survival. Thank you.
Thanks, Dr. Sutton. And never ceases to amaze me how technologically advanced and the sophistication of things that happen in your space. Our final panelist tonight is Dr. Felicia Blow. Dr. Blow is the Executive Director of the UVA Community Health Foundation. She leads philanthropic efforts for the many communities that we serve, including Northern Virginia. Dr. Blow, over to you.
Hi, thank you so much, Dr. Zaidi. I have to first start out by thanking this amazing panel. I've learned so much myself tonight. For example, that comment about those mothers who breastfeed have a lower chance of breast cancer based on what Dr. Green, I mean, it's just incredible the information that's being shared. Thank you all also for joining us as we recognize Breast Cancer Awareness Month. This is one of UVA Community Health's first such conversations in this format to help patients in the regional community understand the special and innovative services that are offered, as well as how we could help educate on ways to enhance your health. As Dr. Zaidi said, I serve as the executive director of the UVA Community Health Foundation. My role involves helping UVA Community Health achieve its strategic priorities by seeking philanthropic support. As you can well imagine, to maintain the innovations needed for a dynamic and world-class system such as UVA Health, we need support. One of the big things that I do in this regard is I work with a cohort, a group of individuals that I call or describe as grateful patients. And grateful patients are described as those who've received excellent care and wish to express their gratitude through philanthropy. And this is done because funding to ensure that advanced medical equipment, new research, state-of-the-art facilities are available, as well as expansion of services, development of new patient programs that otherwise would not be financially viable. But this is the really important reason why patients are so interested in engaging. For some patients, the ability to donate after a positive experience is a meaningful way for them to express their gratitude and to help someone else who has a similar health challenge. Said differently, the clinical experience of contributing to others' care helps other patients, and we can go to the next slide. So it's almost like we're reaching back and paying it forward. There's so many ways to engage, and I want us to be sure to get quickly to Q&A, so I'm going to cut my remarks, but I want to close with this. I invite you to visit the website for the UVA Community Health Foundation. Call me personally. I love direct calls and emails for a tour of any of our facilities. And on this slide, you see Prince William, Haymarket, Culpeper, Gainesville, ambulatory clinics is an expansive array of facilities that are available to Northern Virginians. We also can talk about how you can engage philanthropically in the amazing expansion of the Gainesville Cancer Center, which you heard Dr. Zaidi talk about. World-class cancer care right in our backyard. The other thing I will tell you about UVA Community Health Foundation, every single dollar stays local. In the chat, you're going to see soon a link. It's a wonderful story of triumph over a great trial. A young woman, Justine, learned at the age of 35 that she had early stage breast cancer, described as aggressive, rapidly growing, and proliferating cancer. And in this video, you will see through her experience at UVA Health, which is unlike others, the genetic counseling, the vast array of expertise, similar to what you heard tonight, it went far in ensuring that she is cancer-free today. Please take a look at that video. And then lastly, we want you to visit the program survey link. It's going to be placed in the chat before we conclude, We want to do more of these kind of sessions, but we want to hear from you if it's good, you want to change it. This is an important conversation, particularly in this month. And thank you again to Claire Hedgepeth and the Office of Engagement. You are appreciated. Thank you so much.
Thank you, Dr. Blow. Your work is so critically important as we build world-class programs here in our community. And I'd like to thank all of our guests tonight for attending this event and for your engagement in offering questions for our experts tonight. We're going to conclude with a brief Q&A, and the first question is actually for Dr. Greenwald, and this is from Gretchen. So the question is, do you have occupational therapists and other rehab professionals integrated as part of your cancer care teams? What level of interprofessional collaboration happens amongst the team members for continuity of care? Ian?
Yeah, it's a great question, very relevant question, because we're doing so much better with breast cancer treatment and survival, we can focus on quality of life afterwards. And so things like rehabilitation services, physical therapy are really important and actually considered to be a major form of treatment and survivorship. So the answer is yes, we do have those services. I'm lucky enough that some of our physical therapists are literally in the office just down the hallway from me. But then there are other physical therapists, occupational therapists throughout the UVA Community Health system. And we are implementing a new system in our office, and then also will be at the Gainesville Center in terms of monitoring for things like lymphedema, which can be swelling in the arm after surgery, which is also considered to be something related to rehabilitation services. And then from a collaborative care, it's something that we all kind of we all drink the Kool-Aid on here in this program, in the sense that we all very much believe that we support one another, and by doing that, we'll support the patient's outcomes. So constantly communicating and coordinating care through the tumor boards, like Dr. Sutton mentioned, but then also just through intercommunication throughout the system.
I'd like to add to that, Dr. Zaidi. So in Culpeper, we have the fortune of having the PAL Wellness Foundation that has an oncology rehab program dedicated to cancer survivorship and follow-up care. We work closely with that program. They do also have lymphedema care, occupational therapy, physical therapy, speech pathology, even for some of our patients who are affected with radiation to the head and neck. And so we do have a robust support system that we work with.
Thank you both. The next question is for Dr. Sutton. So Dr. Sutton, are there any dangerous side effects of radiation treatment?
Yeah, so I think I talked about that a bit during my presentation of how we try to avoid any late side effects. But of course, like with any treatment, there's always side effects. So primarily for breast patients, there will be changes to how the breast feels. It can make it a little bit denser. There can be small cosmetic changes. We try to minimize those to the best that we can. But the long-term toxicity in terms of the heart and lung have significantly reduced with the technology to 1% risk or less. And then there's kind of the acute toxicities, fatigue that you get during radiation. That gets better. Sorry, housekeeping here. That gets better in the months after radiation. But the things we worry about the most are the heart and the lung, which we have made significant strides in.
Thanks, Dr. Sutton. I think we have time for one more question here, and so I'll tee this up for perhaps Dr. Patel and then maybe Dr. Majub can follow. Are there any clinical trials currently open at UVA Health to help with research or new therapies? And how can patients in the community learn about them and if they're eligible?
Yeah, I think for breast cancer specific trials, I'll turn that over to Dr. Majub, but we do collaborate well for our main campus. We are working on trying to collaborate with clinical trials within the community as well. But I think Ali had some exciting news about opening trials in Culpeper and Gainesville.
Yep, we're excited. We got our first clinical trial for UVA Community Health for breast cancer patients. And this is and a trial that targets low-risk patients with breast cancer, and it's actually targets the population for easy decision-making regarding treatment and therapy. It's open. We're approved here in Culpeper and Gainesville, and we're ready to recruit patients. Now, for other clinical trials, we collaborate with our colleagues down at UVA. For any information, it's easy to find on the net, uva.com, and clinical trials, if you just put it on the search bar, it's the first link. You will find clinical trials goes by disease type, from acute leukemia all the way down to and specifically for each disease, including breast cancer, goes with different stages, stage 1 or stage 4. And we're happy to refer patients to UVA because we're really in contact with our colleagues down in different disease types. And we can easily get patients in within a few days to be seen by the clinical trial teams and check their eligibility.
Dr. Zaidi, could I make reference to the release that if anybody's interested in, we'd be happy to email to you, that came out from the CEO of UVA Health that talked about how exciting the expansion of our clinical trials for Northern Virginians is for us. And we want to make it easier. Jason Lenine has gone on to say to make it for residents across Virginia to more easily access clinical trials. So there's some documentation that we can share if anyone's interested in a more expansive way on, the long-term view.
Thanks, Dr. Blow. And so 7 o'clock. So this brings us to the end of our event tonight. And in closing, I would like to thank each of our panelists for sharing your time, sharing your expertise. And also to thank all of you who have joined for tonight's webinar. We've included some links here, and so there should be a slide here that we can put up that can allow for ease of scheduling appointments with our experts. We've also shared some information here as to how to contact Dr. Blow for inquiries related to our community health, our UVA Community Health Foundation. And lastly, a big thank you to the UVA Prince William Alumni Club for hosting and supporting this event tonight. Hope everybody has a wonderful evening. Thank you all.